with Steen Levithan way back, and then we moved on to different criteria. So let us see why this entity called as adolescent PCOS is still, troublesome. Is it really a misnomer? One, that is the question. Or have we hyped it? As he was telling, like every, second girl, third girl is coming up with PCO. Have we hyped this entity? That is a big question. So let us try to decode what is there. I'll take you through this for another 20 minutes. So let's first focus on diagnosis part. This is diagnosis of polycystic is based on criteria. And why we require a criteria? Because any heterogeneous disorder, one particular single parameter is not strong enough to make a diagnosis. All right. We take the example of, say, ultrasound findings of polycystics. 20% of women with PCOM have PCOS. PCOM is absent in approximately 20% with PCOS, and PCOM is present in approximately 20% without PCOS. So this is how we started with in 1990, National Institute of Health, NIH gave this criteria. This group was from US. They gave the criteria that we have to have two parameters to make a diagnosis of PCOS. One was oligoanovulation, and second was clinical or biochemical signs of hyperandrogenism. But this was a US group. Then the European group was not happy with the exclusion of ultrasound findings of polycystic ovaries, right? And in 2003, they gave this criteria which is called as Rotterdam, which we are following now. PCOS is diagnosed if two out of the following three criteria are included: oligoanovulation, clinical androgenism, clinical or biochemical signs of hyperandrogenism, and presence of polycystic ovaries. Then in 2006, Androgen Access and PCOS Society, they changed slightly the criteria, because then what they did was they kept hyperandrogenism as a compulsory parameter. So it has to be there, and associated with that, one has to have either ovarian dysfunction in the form of oligoanovulation or a presence of polycystic ovaries. So now what are the challenges, especially in terms of diagnosing in adolescent PCOS? Because features of normal pubertal development overlap with adult PCOS diagnostic criteria, hence caution should be taken before diagnosing PCOS without longitudinal evaluation. So we have to, over a period of time, if we find that these changes remain or they exacerbate, then we probably think this to be because there is a strong overlap. In addition, rising prevalence of obesity in pediatric population may compound insulin resistance in girls predisposed to ovarian hyperandrogenism, leading to younger age of presentation and more severe phenotype. So these are the challenges. So what happened was, then the international evidence came and for adolescents, and they give this updated Rotterdam criteria. They said in 2018, they said OA and HA, they have to be there. They avoided PCOM for PCOS diagnosis. So now only two parameters were there: oligoanovulation and hyperandrogenism. So practically, we came back to the original criteria. If we compare this with the 1990 NIH criteria, it also had the same thing, no? Oligoanovulation and clinical or biochemical. So updated Rotterdam criteria is probably nothing but reverting back to a 1990 criteria, which is applicable only for the adolescents. And for the adults, we have either the AI Society or Rotterdam criteria, whichever you follow. All right. Now, this is, however, this recommendation is based on expert consensus with limited evidence on most accurate diagnostic approach in adolescents and on the natural history of PCOS phenotype over time. It remains unclear if this particular updated criteria really captures adolescents with PCOS who are at the greatest risk of long-term complications and would benefit the most from a lifestyle preventative interventions. So this is the criteria. 2020 again we came up with. Then we defined what is the irregularity and ovarian dysfunction. This is again very important. And as far as hyperandrogenism is concerned, this is again important. We'll get into this slightly later on a detailed this thing. So then this came in 2023, which is again based on 2018 guidelines. International evidence-based guidelines came from all the Monash University, ASRM, European Society, ESHRE, European Society of Endocrinology and ESHRE. So then they defined these entities, no? So first off is, how do we define irregular cycles, or what are the irregular cycles? Normal in first post-menarche as part of a pubertal transition. So any irregular cycle in first post-menarche is not taken into consideration. From 1 to 3 years, so any cycle which is less than 21 days or more than 45 days is taken into consideration. 3 years post-menarche, this changes to 21 days and 35 days. From here, it was 45 days. Now it has gone to 35 days in 3 years post-menarche, or we have less than 8 cycles per year. Then 1 year, in 1 year post-menarche, any cycle which is more than 90 days, we consider this as irregular cycles. Or we have a primary amenorrhea by age 15, or if it is more than 3 years post-hilarchy amenorrhea, then we call this as a irregular cycle. Now, when irregular menstrual cycles are present, a diagnosis of PCOS should be considered and assessed according to these PCOS guidelines. For adolescents who have features of PCOS but do not meet the diagnostic criteria, an increased risk or at risk could be considered and reassessed at or before full reproductive maturity, usually 8 years post-menarche. Now, what is the ovulatory dysfunction can still occur with regular cycles, and if anovulation needs to be confirmed, it has to be confirmed by serum progesterone levels on from day 20 to 24. This is the recommendation now. Now, why these criteria came? Because see, we see 1 year post-menarche, we have around slightly more than 80% which are anovulatory cycles. Red denotes anovulation. 3 years post-menarche, we have around 60%, and 6 year post-menarche, we are left with just 20-25%, which are anovulatory cycles. The cycle length also varies. If it is more than like it is if in 80 to 8, right, more than 80%, it is more than 40 days, and then we have that is how we came up with the in ovulatory or irregular menstrual cycle criteria. Now, coming on to the second part, which is important, is hyperandrogenism. Now, before I really go to hyperandrogenism, I just want to explain one condition which is called as a functional hyperandrogenism of puberty, or what we call as a transient hyperandrogenemia of puberty. So this is a temporary phase which is occurring during puberty, and it over a period of time it goes away, right? So in this, Ferriman-Galway score is not very useful because this score has been standardized for white women who are more than 24 years of age. Now, coming to how do we diagnose hyperandrogenism, which is PCO related. Hirsutism defined as modified Ferriman-Galway score 4 to 6. Some people say more than 8, but usual recommendation is anything more than 6 is important, and or severe acne or inflammatory acne more than 10 on face. And rarely we have alopecia also. So, but one recommendation is again now coming up that in adolescent, Ferriman-Galway score of even less than 6 can be considered. So this is the Ferriman-Galway score. What modification in original had the counting of 11 sites. 2 sites have been deleted. Now it is from the 9 sites only. The forearms and the legs part has been excluded now. So now this is Ferriman-Galway modified score. The coming on to acne, we have either the severe acne, because mild acne is again a part of pubertal development. We have a severe acne, or we have a ulcerative type of acne, and it should be more than, say, roughly 10 on the face. We then consider this as a part as a sign of hirsutism. Alopecia, some people say again it has to be, has some importance, but not many studies are there which recommend alopecia as a criteria for hirsutism. Now, how do we measure biochemically this hyperandrogenism? In females with irregular cycles, yet without clinical hyperandrogenism, in these cases, we will do a biochemical test or laboratory test. In most adolescents, androgen levels reach adult ranges at around 12 to 15 years of age. Total or free testosterone can be tested. Free testosterone or free androgen index can assist with diagnosis, although no cutoffs have been given. If testosterone or free testosterone is not elevated, healthcare professionals could consider measuring androstenedione and DHEAS, noting that they have a poor specificity and greater age-associated decrease in DHEAS. Then, the most important part is laboratories should use validated, high-accurate tandem mass spectrometry, liquid chromatography, LC-MS assays for measuring total testosterone and if needed for androstenedione and DHEAS also. But unfortunate part is that these high-end investigations or facilities are not available in all hospitals. So it again becomes difficult for us to really document biochemical hyperandrogenism. Again, another part is any women who is using COCP, combined oral contraceptive pill, it is really difficult to assess biochemical because the SHBG is increased, which reduces gonadotropin independent androgen production. If patient is already on COCP, then 3 months withdrawal is required before we test for biochemical and hyperandrogenism. A word about free androgen index. Typical values in a women are 7 to 10. It's a ratio between total testosterone and SHBG multiplied by 100. The concentration of testosterone and SHBG are normally measured in nanomoles per liter, but there is no unit for FAI because it is a ratio. Majority of testosterone in the blood does not exist as a free molecule. Instead, around half is tightly bound to SHBG and the other half is weakly bound to albumin. Only a small percentage is unbound, under 3% in males and less than 0.7% in females. Since only free testosterone is able to bind to tissue receptors to exert its effects, it is believed that free testosterone is the best marker for a person's androgen status. However, free testosterone is difficult and expensive to measure because it requires a time-consuming dialysis steps and many laboratories do not offer this service. So that is why we do a FAI. A word about AMH, just to say that AMH is not recommended in adolescents as anything because 2023 guidelines added AMH as a diagnostic criteria or a helping criteria in diagnosing adult PCOS, just to negate that thing that this has no value in adolescents, this particular thought. And usually because it usually peaks between 20 to 25 years, so it has no value in adolescents. Now, the next question is the incidence high? Or what Dr. Ramesh was telling that no epidemic, every third patient is coming up. Now, updated in a study in 2020, they said that using updated Rotterdam criteria, only 18 to 13% of females had, incidence of adults also, and same for the adolescents also. Another study in International Journal of Reproductive Medicine and 2029, they said that they applied different criteria. At Rotterdam, it was 11%, and based on NIH criteria, it was 3.39%. So when I'm talking of NIH criteria here, it indirectly means updated because it is similar to NIH criteria. And then it came to be just 3.39%. This means out of 100, we'll just have 3 or 4 100 adults, we'll just have 3.3 adolescents. And based on AI Androgen Access Society, it was 8%. So anyway, it is not that something like epidemic of PCOS occurred, and probably we are overdiagnosing. Another study in Lucknow, India, we had just 3.7% women, girls who are had polycystic ovaries. Now, coming on to the next controversial story, is it a misnomer? Why I call this as a misnomer? Because a high prevalence of polycystic ovarian morphology may be observed during adolescence, so PCOM is not a useful criteria as told earlier, so it is out of picture. In addition, since PCOM is not clearly associated with hyperandrogenism during this period of life, the term polycystic ovary syndrome during adolescence creates confusion and may be misleading. So, where does ovary stand? One, it is not showing any concrete evidence of PCOM because at this point of time it is not reliable. Secondly, it is not really associated with hyperandrogenism also, because this really needs a in-depth study that how much of androgen is really coming from the ovary, because only what the literature said is only 25 to 30% of androgen comes from ovaries, rest comes from peripheral conversion or adrenals, right? So if ovary is nowhere in the picture, why name it as a polycystic ovary? So is it time to change terminology of adolescent PCOS? This is a big question. Probably yes. This terminology is indeed being reconsidered by experts. Since puberty naturally causes hormonal fluctuations, diagnosing PCOS in adolescence is challenging, and some researchers argue that the term may lead to overdiagnosis or unnecessary anxiety. Recent guidelines also suggest that adolescents with only one diagnostic feature should be labeled as at risk rather than being formally diagnosed with PCOS. This approach allows for symptom management and follow-up without prematurely labeling a condition that may evolve over time. Now, what will be the impact if we change this terminology? We will be reducing overdiagnosis. By refining criteria and terminology, adolescents who are at risk can be monitored without prematurely labeling a lifelong condition. We'll have better treatment strategies because a more precise name might encourage targeted approach, because one size fit all PCOS diagnosis is not there. Less psychological risks, because avoiding an early diagnosis might help reduce anxiety and stigma, because every second girl like she goes through Google and finds out that there is something called as PCOS, and then she comes to you and says that I have a PCOS without really having any symptom of PCOS. Probably some sonologist has labeled this as just one finding of PCOM, which as a something on ultrasound. So more personalized follow-ups will be there if we rename change the terminology. Now, what are the proposals which have been, one is at risk of for PCOS. This is the one term which has been suggested even in recent guidelines. Second is hyperandrogenic anovulation. Some experts propose this term to emphasize the hormonal imbalance and ovulatory dysfunction rather than the ovarian morphology, because hyperandrogenic anovulation means this satisfies both the criteria, all right, which are in their updated Rotterdam. And third is a ovarian dysmetabolic syndrome. This name highlights the metabolic aspects of PCOS, which are often overlooked in the current terminology. And then metabolic reproductive syndrome, another alternative that focuses on the systemic nature of PCOS rather beyond just ovarian dysfunction. These changes aim to improve diagnostic clarity, reduce stigma, and encourage personalized treatment approaches. Now, what are the challenges with renaming adolescent PCOS? One, there will be a diagnostic uncertainty because it will be harder to distinguish in between normal development and actual PCOS. It will be difficult for medical professionals who would require new clinical adaptations and new clinical updated diagnostic criteria. So we have to again go back and find or define new criteria. Patients again have to be made aware and education. They may struggle to understand the implications of a new term, leading to confusion about symptoms and risks and management, because they have been accustomed to listening to the word PCOS. Research and data standardization again will be difficult because when we do a long-term research comparisons, we look into the previous data or previous studies where there will be a PCOS, and then we'll not be able to really standardize that data. Insurance healthcare policies will again be difficult because a new term might affect insurance coverage. Despite these challenges, refining the terminology could help reduce stigma, improve diagnosis, and encourage personalized treatments. Now, how do we really address these concerns? We have to update guidelines, like latest guidelines said at risk for PCOS. Then we have a shared decision making. They can involve the adolescents in discussions, avoiding overdiagnosis. Experts stress that PCOS morphology should not be used for diagnosis in adolescents. Long-term monitoring, adolescent symptoms are advised to undergo regular follow-ups to track hormonal changes and metabolic health. Multidisciplinary care management strategies now include lifestyle interventions, psychological support, and tailored medical treatments. Except for the part that girls are girls and they come to a gynecologist. Otherwise, where are we really involved in terms of having a hyperandrogenism? Except for that, she comes to us for irregular cycle. That is part which we are concerned with. But for any long-term management in terms of long-term complications, other people can also be involved. These efforts aim to balance early intervention with avoiding unnecessary labeling, ensuring that adolescents receive appropriate care without premature diagnosis. Now, what is the opinion? Conclusion comes to this is the lessons we have learned. There has to be a need for careful approach and diagnostic criteria to provide timely diagnosis during adolescence. Diagnostic criteria should avoid overdiagnosis that causes unnecessary concerns. Close follow-up of adolescents at risk of PCOS who do not fill the diagnostic criteria. Education of healthcare professionals about the diagnostic criteria. Multidisciplinary approach. If adolescent fulfills only one of the diagnostic criteria, they may be considered at risk, as previously told. Some experts suggest labeling adolescent as at risk rather than diagnosing PCOS outright, allowing for symptom management and reevaluation over period of time. Now, how do we manage? A word about management. Lifestyle interventions like exercise and diet management. Not going into really details, but exercise is one important factor. One may not focus really stress on weight control measures. Even exercise in itself leads to a decrease in hyperandrogenism. Combined oral contraceptive pills may be used in adolescents to take care of their irregular cycles. Metformin can be used alone or in association with combined in association with COCP. It has been shown to be more beneficial. Now talk a word about inositols. Although new guidelines do not recommend inositols, but they say it is not that harmful also, so one can consider. But as far as I am concerned, since inositol or these are neurotransmitters, so what I always feel is that giving inositols may take care of the psychological or anxiety issues in these young girls. So inositol at any point of time is not a bad story. So cosmetic therapies like laser and light therapies can be considered. So another question which now comes is, what will happen if we delay the diagnosis? While some experts advocate for careful monitoring before confirming a diagnosis in adolescents, waiting too long can result in unmanaged symptoms and increase health risks. So now what are the unsolved questions? Which subset of patients are really at risk of long-term complications? Am I supposed to tackle all at-risk patients and follow them up for a long period of time? Or I can find one subset of patients who are really at risk of long-term complications, so I can follow only those patients. I wish I knew if